This afternoon, we're privileged to really have a very special guest speaker who's part of the panel. And I met Luke Murphy, who put together a really excellent presentation. This is always a challenge because though we take it for granted, when you look at the panel that we've been able to put together for this topic, I'm always in awe of the local expertise that we have that really serve as a stellar panel. And several of the people certainly merit international renown, and we're really privileged to have such an august panel. The topic for today's controversies, approach and timing of advanced therapy in end-stage heart failure, and people like Sean Penny and Donna Mancini have really been pioneers in the field and really dramatically impacted the field, and really privileged that they're part of our faculty and we take advantage of them on a regular basis. Donna's away today, otherwise she'd be privileged to be on the panel. The visiting professor you'll hear more of, but it was a warm homecoming for Dr. Kobashigawa, who is a medical student here. Dr. Fuster will tell us more about it. I also had in the back the schedule for the visiting professorship. Mike Gibson from Beth Israel Deaconess was going to be here in December, but was asked us to reschedule, so he's going to be here on February 4th. In December, he's going to be appearing at an FDA committee meeting, so we had to cancel. We didn't want to lose him, so we put him on February 4th. The rest of the schedule is self-explanatory. The other members of the panel, again, no less august than Dr. Penny, who will moderate, Dr. Anu Wanu, who is a professor and vice chairman, director of heart transplantation, mechanical circulatory support, whose innovations in transplant and LVAD have really also revolutionized the field. We're privileged to have him. Maya Burgash, very important leader in advanced heart failure, pulmonary hypertension. Laura Gelfman, interestingly enough, who's been a major contributor to the heart failure field because of her expertise in geriatrics and palliative care. Noah Moss, who's contributed significantly as a young faculty member, both to the heart failure team as well as to a general fellowship, and I appreciate his presence on the panel. Dr. Mateer, also junior faculty, is going to be opening up amyloid specialty clinic. Dr. Pawali, who I'm surprised was able to be here because he's on call 24/7, nonstop, taking care of the most ill, sick patients, advanced heart failure in the hospital. And it's always a privilege to have him here and the great assistance he's given to our fellowship program. I'm already taking too much time from Luke Murphy, who put together, if you have the opportunity, please read a very detailed monograph that he put together. And of course, the difficulty is sort of summarizing it very briefly, as he's now going to try to do.
Thank you all for coming to this month's Controversies in Cardiology. I'd like to offer special thanks to Dr. Kobashigawa. Thank you for traveling across the country to visit us. It was an honor to spend the day with you and to learn from your lecture this afternoon. I very much look forward to the upcoming discussion. More than 37 million patients worldwide carry the diagnosis of heart failure, with some 30 to 40% of these patients having heart failure with reduced ejection fraction. While the use of guideline-directed medical therapy, implanted defibrillators, cardiac resynchronization therapy have dramatically improved outcomes, and while new therapies like MitraClip in heart failure patients with severe mitral regurg may promise further gains, currently 0.5% to 5% of HFrEF patients, encompassing some 250 to 500,000 people under the age of 75 in the United States, do not respond to therapy and progress to advanced heart failure. Prognosis in advanced heart failure is poor. Heart transplantation is the gold standard treatment for advanced heart failure in patients without contraindications. Continual improvements in immunosuppressant regimens, donor procurement practices, surgical techniques, and post-transplant care many of which have been spurred along by Dr. Kobashigawa, Dr. Mancini, Dr. Pinney, and others in this room, have led to a substantial decrease in acute allograft rejection and improved outcomes among post-transplant patients. Additionally, major changes were recently introduced to the donor allocation system in an attempt to render more efficient access to donor organs for the sickest patients. However, limitations to long-term allograft survival, including rejection, coronary allograft vasculopathy, and post-transplant malignancy, and limitations to access to donor organs still exist, meaning that transplant can only go so far in addressing the burden of disease for the advanced heart failure population. To wit, estimates suggest that up to 150 to 200,000 patients in the United States would benefit from cardiac transplantation. UNOS documented 3,244 transplants in 2017. LVAD has long been held as a therapy that would be able to bridge the gap between supply of donor hearts and demand for advanced hemodynamic support. And progress since the first LVAD was implanted by DeBakey in 1966 has fueled optimism about this technology's promise, from bulky, pneumatically driven devices to fully portable systems, from pulsatile to continuous flow hemodynamics, and in the latest iteration to a fully magnetically levitated centrifugal flow pump that has dramatically reduced the rates of pump thrombosis. Increased experience with postoperative management has led to gradual reduction in adverse events. New surgical approaches, allowing patients to avoid a median sternotomy, have shown great promise. Our own Dr. Ani is among those on the forefront, generating an evidence basis for these new approaches. With these advances has come an expansion of the patient population thought to be appropriate for LVAD therapy. The roadmap trial in 2015 showed that while early implantation of LVAD in healthier advanced heart failure patients fitting into Intermax profiles 4 through 7 did not necessarily improve mortality, it did significantly improve quality of life and measures of functional capacity. LVAD implantation is also an appealing strategy in advanced heart failure patients with potentially reversible comorbidities that render them ineligible for transplant, a so-called bridge to candidacy approach. Advanced heart failure patients with obesity, pulmonary hypertension, and frailty may see these comorbidities improve with hemodynamic support provided by an LVAD, allowing them ultimately to be listed. Exciting interim data from the ReStage heart failure trial have shown that with proper patient selection, LVAD support may even be a means for myocardial recovery, ultimately allowing for explant of the device. Finally, there is active inquiry regarding patient and device selection for mechanical support in the setting of acute heart failure, and interest in earlier empiric LVAD support perioperatively in patients with complex valvular disease. It is hoped that new medical and device therapies for patients at risk of advanced heart failure, reconfiguration of the donor allocation system, advances in care for post-transplant patients, rapidly advancing LVAD technology, and active inquiry into emerging indications for mechanical support in the acute setting will combine to ease the burden imposed by advanced heart failure. Already many patients who in previous decades would have succumbed to their illness are now alive and with dramatically reduced burden of symptoms. As always, shared decision-making and involvement of an interdisciplinary team are of paramount importance to this endeavor. Thanks.
I have been making rounds with Luke over the last 3 weeks, and he really came with a new suit today. So I said something is going on. Anyway, thank you very much. It's a very good summary of the subject that is going to be discussed, and certainly it's a pleasure to introduce Dr. John Kobashigawa, who is very well known in the field of heart failure and transplantation. He, just going back to his history, I would say that he had he started in California, Stanford, where he went to college, and then he moved to New York, was at Mount Sinai School of Medicine, and when he finished here, was in 1981, he moved again to California, to UCLA, and he had his internship, his residency, and his fellowship at UCLA, and in 1986, he became a staff member as a clinical instructor, and he moved progressively into the to be medical director of the UCLA heart transplant program, clinical professor of medicine, etc. Then was, for about a few years, he was the chief medical officer of the California Heart Center Foundation. And he finally, in 2010, he moved to Cedars-Sinai in Los Angeles, where he became the Thomas and Gordon Chair of Medicine Professor and Heart Transplantation Medicine Directorship. Now in Cedars-Sinai, he has done a fantastic job, and I can just summarize that whether he's at Sinai, at Cedars-Sinai, or nationally or internationally, he's a very well-recognized individual. First of all, he has a number of appointments in the national committees, Board of Directors of the International Society for Heart and Lung Transplantation, 1997, 2004. He was the program chair of scientific sessions in Japan later on, and finally he became the president of the International Society for Heart and Lung Transplantation in 2003-2004. He is in the board of directors of the American Society for Transplantation in 2016 to 2019, and he has directed consensus conferences in heart transplantation 9 times. And he has been the chair of the UNOS, which is the allocation of transplantations in the United States in 2015. So he has numerous awards that started from young age, and then he moved into UCLA at the beginning when he was already in the staff as the clinical faculty teaching award. And then he was a number one after the other in at different stages of his career. I was curious about one of the 10 top doctors of the Hollywood Reporter. You have to tell us what this is, how you get there. But it's one of the many awards that he got. And then I want to mention he is in the editorial board of all the journals, actually, national and international, that actually deal with transplantation. He's very prolific. He has been very much an investigator. He has about 800 papers. And actually, the papers are related to, I went over transplantation, heart failure, imaging, biomarkers, but all related to an entity that is becoming so attractive today to actually the young fellows, which is heart failure, transplantation, left ventricular assist devices. He really has contributed to all of these, and it's a pleasure to have you here today as a visiting professor, and I forgot to give you the plaque. I forgot the plaque, and I'm sorry it's in the floor, but it means a lot to us. Here's just for you to remember. The check amount, don't remember. Okay? But the plaque says to John Kobashigawa for outstanding teaching wisdom and expertise as the Anandi Sharma visiting professor in the Simon Dack Memorial Lecture. You probably remember Simon Dack.
Oh, yes, very much so, yes,
Indeed.
yes.
Even when you were medical student
Yes,
here.
yes.
Yeah.
Along with Dick Orland and Louis Tischler.
Yeah. Anyway, it's a pleasure to have you here today.
Very
Okay?
good, thank you so much.
Congratulations. Thank you. Okay,
Yeah,
thank you
thank
very
you so
much. And now we are going to call Dr. Sanpini as going to be the moderator, and then they already mentioned all the stars that are going to be part of the panel. Anis here, Maya Vargash, Laura Gelfman, No Moss, Sumit Singh Mitter, Amit Pawali, and then, of course, Luke. So many people who are going to contribute. Okay, Sam.
Thank you very much, Dr. Goldman and Dr. Fuster. You know, when I reflect on the field of heart transplantation, what immediately comes to mind are two living legends, and I can't tell you how privileged I am to be able to work with both of them. First is Dr. Donna Mancini, who unfortunately couldn't be here today because this topic is so germane to her work and her leadership. You know, she is the person more so than anyone else who has led this field in terms of selecting appropriate candidates, particularly those who are ambulatory with heart failure, to know when it's appropriate to list for heart transplantation. And she's off exploring the Galapagos Islands right now, so she thought that was more important than coming to Controversies. And then the other, of course, is Dr. Kobashigawa. And you know, as a young physician, I looked up to Dr. Kobashigawa, and I still look up to Dr. Kobashigawa because of his leadership. For those of us who practice in the field of heart transplantation know how much John's stewardship of clinical trials has influenced everything that we do, from the selection of immune suppression to the prevention of cardiac allograft vasculopathy, and his current leadership in understanding the complexities around antibody-mediated rejection and how to develop and test new diagnostics so we can eventually get rid of the abhorrent endomyocardial biopsy. So anyway, it is a real pleasure for me to be able to moderate this session and to spend some time with Dr. Kobashigawa this morning. So what we're asked to talk about today is selecting patients for advanced therapies for heart failure. And this morning on rounds, we had an opportunity to really get into the weeds with some really challenging cases upstairs, and we benefited from Dr. Kobashigawa's insights about some of these patients. But I thought what we should do now is kind of just zoom the camera back, if you were, sort of a Hollywood analogy, you know, right up Beverly Hills and that sort of thing, and take a 30,000-foot view about advanced heart failure. And so, Maya, I'd like to start with you. I mean, we talk a lot about advanced heart failure, but you know, can you define it for us? Because one of the things that we hear, and this will be germane to our conversation this afternoon, from referring cardiologists is like, when should we refer? So how do you define stage D heart failure, and when is it appropriate to refer patients for evaluation for advanced therapies?
Thank you. Hello, everybody. Thank you to Dr. Kobashigawa for visiting us, and it's really a privilege to get to meet you, and thank you to Dr. Murphy for the great presentation. I think that's a very important question. I don't think that we know exactly how to define stage D heart failure, which is, I think, part of what makes it challenging to figure out who to refer. Luke had mentioned certain profiles that can identify patients who come in acutely, and I think in those cases it's much more clear that patients who come in with cardiogenic shock, who you can either stabilize or not stabilize, are patients who are very high risk and who warrant an evaluation for advanced therapies. But the ambulatory patients that we see on a day-to-day basis in the clinic are patients that are harder to characterize. There are some, clinical clues that we recommend, or at least have guidelines about, because we know that looking at those characteristics have shown to portend a poor prognosis. Some of them involve risk scores, but others are clinical characteristics. So, for example, patients who have a low blood pressure who are not able to tolerate neurohormonal blockade, or patients who have previously tolerated those medications, but you're seeing that you have to down titrate them because they're intolerant to those medications. Patients who have worsening renal function, increasing diuretic requirement, increasing ventricular arrhythmia burden, and frequent heart failure hospitalizations are sort of the grab bag of people who are identified as higher risk. And then there are certain other testing characteristics that can identify higher risk patients who are ambulatory, particularly Dr. Mancini's work in using cardiopulmonary exercise testing to help risk stratify patients. So in every patient I meet in the heart failure clinic with HFrEF, I perform a cardiopulmonary exercise test to more objectively assess their functional capacity and also their cardiac limitations to exercise capacity, because we know that that's a very strong predictor of poor outcomes.
Give me a couple other take-homes. So certainly an inability to tolerate neurohormonal antagonists. And this was great work that was done by Dr. Kobashikawa's colleague at Cedars, Dr. Michelle Kittleson, showed that those individuals who you had to withdraw an ACE inhibitor or, God forbid, withdraw an ACE inhibitor and add an inotrope had a terrible one-year survival. Inability to exercise, so limitation to walking, let's say a city block or two, or climb a flight of stairs. What about hospitalizations?
So frequent heart failure hospitalizations, so more than 2 or 3 in a year would be one to think about. In terms of specific numbers on a cardiopulmonary exercise test, peak VO2 less than 14 cc's per kg for patients who are not on beta blockers, but less than 12 for patients who are on beta blockers would be more specific numbers.
Noah, what do you think about defibrillator shocks? Are those prognostic or not prognostic?
Yes. Yeah, definitely they do have prognostic value in terms of outcomes with heart failure patients.
So it's a marker of a bad outcome.
Yes.
Do you think it contributes to the bad outcome, or it's just associated with bad outcome?
I think we've seen it both ways, where it is just a marker of it, but also when it's just a sign of a patient spiraling down. And I think just having the heart failure consult at that time is helpful to maybe decipher which one it is and to work through the case from that point of view. So not waiting till they're spiraling down, not waiting till they're in the hospital, that's probably just as appropriate, referring at that time. Especially when the goal in society today is to prevent people from going to the hospital. I think if we wait for hospitalizations, we'll miss a lot of patients where we should be intervening much earlier. So.
Great. So John, you certainly have heard many, many people in our field say the same thing, which is, I wish they had referred the patient sooner. And I'm absolutely convinced that cardiologists want to do the right thing. They want the best things for their patients. They work tirelessly to keep up with the literature. They really do work long hours and work very hard to do the right things for their patients, and yet somehow advanced heart failure patients seem to slip by. And sometimes they come in and write heart failure and they say, well, maybe they had a PE. In reality, it's just bad heart failure. Just, you've been in this field now for so many years. Mm-hmm. What's your take on that? Why is it so hard to identify advanced heart failure patients when we are looking so diligently for them?
I think they just don't recognize optimal medical therapy. When you look at, surveys as to how well the outpatient care of advanced heart disease is being done, very few actually are being treated with optimal medical therapy. And that was one of the problems with the COAPT trial, because the patients weren't being treated with optimal medical therapy, and hence they were all doing poorly. And that's why the initial study showed no benefit, but the second COAPT trial itself showed benefit because they were being taken care of by specialists. And that seems to be the problem in the community. They're not being optimally medicated, they're not getting better, and they don't realize that they're not treating patients the correct way. I think we just need better education, out there in the community. And also these patients are coming in, as you mentioned, in cardiogenic shock. They're coming in as Intermax 1. And once you get to that point where you're getting to serious trouble with multi-organ system failure, there's not a lot that one can do, and these patients are the ones that don't do well. It's the Intermax 4, 5, 6, 7 that truly I think should be recognized, and they're not easy itself too. They're the ones that have shortness of breath with minimal activities or some limitation of activities, but they're ambulatory. And these are the ones that truly would benefit as well, just from the roadmap trial. Perhaps these are the ones that we may be able to extend the ability to give VADs to and improve quality of life, not necessarily survival, but at least quality of life.
I'm so glad that you brought up optimizing medical therapy, and I just wanted to thank Dr. Fuster for publishing the really nice roadmap paper. I say roadmap because really what it is, it's advice to clinicians about how to initiate and escalate therapies for heart failure patients. And this was presented as a clinical pathway, published at the end of last year. Really a fantastic document with a lot of good advice to overcome some of those barriers that you mentioned, John, about initiating and escalating therapy. And I think one of the things that we'll learn this afternoon is too often what appears to be clinical stability is really not stability, that these patients are actually at high risk of dying. And I'll put up a slide. You mentioned COAPT. I'll put up a slide from COAPT as well. But I think it's important to keep in mind that when you talk about patients with stage D heart failure, and even those patients who are not quite stage D, you're looking at a one-year mortality of anywhere from 25 to 75%, which clearly is worse than most cancers, and yet many patients can be sitting in front of us and saying that they feel okay. There can oftentimes be a disconnect between what they report and really how sick they are. And so I think our first responsibility as heart failure cardiologists is to make sure that we do everything possible to maximize medical therapy, and that means increasing the doses when patients are clinically stable and backing down on them only when they're clinically unstable. You mentioned in your very, very nice summary, Luke, about multivariable risk scores. You mentioned tangentially a little bit about the Seattle heart failure model. Can you tell us a little bit more about the Seattle heart failure model? What is it, and when is it applied?
Yeah, sure. So the Seattle heart failure model was sort of a multivariate model that was developed to help, I guess, triage illness severity in advanced heart failure patients. The ISHLT guidelines for transplantation actually list using the Seattle heart failure model as kind of part of the decision making when you're thinking about listing someone for transplant. When you actually go on the website, it's actually pretty cool. There are a lot of different variables you put in, and I can't remember off the top of my head. There are a lot of them, but it gives you a readout of the actual expected mortality. And in multiple different cohorts, it's sort of been validated that the estimates that they give are fairly spot on. And so I think in advanced heart failure can be used in for kind of multiple different purposes, but mostly to just give you an idea of the expected mortality of the patient who's sitting there in front of you.
So not to put you on the spot, but have you ever used it?
I was on the website a few days ago, but I was just making things up. I've never actually used it for one of my patients.
Now I'll take you off the spot. Noah, do you use it?
No.
Maya, do you use it?
I do use it. I think it's been a little more helpful for the ambulatory patients and the cohorts that it's been validated in. And the guidelines recommend that if the one-year mortality is over 25%, that's sort of one of many other criteria that you can look at when you're thinking about referring for advanced therapies. Some patients even ask, they actually want to know specifics, so I find it, if they're interested in seeing kind of on a group level what that might be, it can be helpful for some patients as well. And then I have to plug the heart failure survival score.
Hold that.
Yeah.
Let me go to Smeet. Smeet, do you use it?
He's not here.
Do I use it?
Yeah.
No.
No. John, do you use it?
No.
Okay. Now you can plug the heart failure survival score, and then I'll go back to the Seattle heart failure model.
No, it's a score that was actually developed by Dr. Mancini, who is not here with us today, but incorporates the variables that you get from your cardiopulmonary exercise test, which is one thing that the Seattle heart failure model doesn't do. So I think it's always interesting to sort of see how, or objectify how your patient may look in a population level, but it's not the only criteria that should be used.
So just for completeness, I don't use the Seattle heart failure model either, and the reason is because of this. I have to tout my fellow St. Louisan and expert popular philosopher Yogi Berra, who said it's tough to make predictions, especially about the future. And that's really the problem with the Seattle heart failure model, which is that it's really difficult to make predictions about the future. Ani, let me ask you, why do we rely so much on multivariable risk scores? And are we putting undue faith in these multivariable risk scores? And by extension, then, are we doing the right things by not using them here at Mount Sinai?
Well, you've just shown that we don't rely on them. So why are you asking me why we do rely on them? Because your whole faculty ignores them.
I would say as a broader heart failure community, there are a lot of people who rely on the Seattle heart failure model. And I think one of the strengths of the Seattle heart failure model, if there is one, is that you can frame a conversation with a patient, and you can say that, I would say that in general, when you talk to heart failure patients, there's a great disconnect between their expected survival and their perception of what their actual survival would be. And one of the ways to then frame that conversation and bring them into a more realistic realm is to use the Seattle heart failure model to say, no, you're not going to live to be 80, and no, you're not going to live 10 years. Your predicted survival may be 3 to 4 years, and it's a good place to start the conversation.
I think there's another benefit of the Seattle heart failure model, which we probably should use more, not for predicting, but to demonstrate to patients. What you could do with the model too is plug in how an intervention will change their survival. So I think that's a part of it. When we talk about escalating therapy, that's something that's nice to show a patient in front of them. You know, by getting put on an ACE inhibitor, we decrease your survival this much. By getting an ICD and so on. So whether we relied on for predictions or not, that would be a nice way to show a patient in front how therapies can improve survival.
I think the other thing, Sean, on a practical level, what you need from the risk scores is to identify patients who will not do well. And these risk scores uniformly can't do that. Like if you had a risk score that could say, well, there's a 90% chance you'll be dead within a year, then that's easy to refer those patients. But usually if you go to this whatever Seattle thing you're talking about, and you put in the data, you usually get something like 80%, 85% 1 year survival, 90% 1 year survival. And what do you do with that information? Do you overtreat 8 people to benefit 2 people? Because at the end of the day, that's what you're doing. And the reality is these risk scores don't have sufficient discrimination to tell a survivor from a non-survivor. So that's what makes it a useless clinical tool.
And yet, I would say if you look at the heart failure survival score, though, it actually shows pretty good discrimination. I might say that it shows good discrimination, but the calibration is off. And you know, if we talk, instead of selecting patients for heart transplant, and talk a little bit about selecting patients for left ventricular assist devices, the HeartMate 2 risk score is frequently employed, and it runs into the same challenge, which is that it may discriminate groups into a low or a medium and a high risk group of suffering an adverse outcome, but the calibration is off. Would you agree with that?
Yeah, to some degree, but it still doesn't tell the survivor from the non-survivor. And on the lower risk spectrum, it doesn't tell those who will do well with the intervention you plan. Because if you take a low-risk patient, you subject them to surgical therapy, and they die, you haven't necessarily done the right thing for that patient. So even in the low-risk spectrum, you can't tell those who will benefit from those who will not. And that's the question every clinician wants to know is, will they benefit from the treatment? Do the benefits outweigh the risks? And the risk scores are very difficult. No risk score can answer that well, except for the extremes. And most patients are not in either extreme.
What's your takeaway on the STS score? Many of us rely upon that to also frame risk before considering high-risk surgical interventions. Do you rely on STS?
Not for high-risk interventions. No, it's a good population tool. So if you have a population of patients and you're figuring out you want to adjust for risk, it's useful. But for an individual patient prediction, it's not useful at all.
Let me change gears a little bit and talk about frailty. And I know, John, you've done a lot of work in this area looking at frailty. It's certainly a term which has become much more familiar to those of us who practice cardiology. I wonder, Samit, what's your definition of frailty? What does it mean to have a patient in front of you who looks frail?
I mean, when I look at a patient and try to figure out frailty, first of all, Dr. Kabashigawa, thank you. It's nice to have another Californian in the room here. Frailty. I look at a multitude of factors, and I think it's hard to actually give us a concrete definition. And we've tried them many times to say this is actually frail. But when I look at a patient, I look at their age, their BMI, their nutritional status, looking at their albumin, their prealbumin, gait speed, and even Dr. Mancini has done work previously on hand grip strength. And so we try to implement those tools as an outpatient, as an inpatient, to figure out who we define as frail. It's not an exact science, but those are the tools we usually use.
So John, you've led multidisciplinary conferences trying to get at this issue of frailty. And how do you define frailty? Which indices do we use? Are they useful in predicting outcomes for VAD and for transplant?
Yes, we had put together a consensus conference on frailty for all organs, actually, and including liver, kidney, heart, lung. And we use the Fried phenotype scale. In the Fried scale, there's a mnemonic way at WEIGH. W is for weight loss, E is for exhaustion, I is for inactivity, G is for gait, gait speed, and H is for hand grips. And as it turns out, if you have 3 of the 5, then you have frailty. It's different from the eyeball test. A lot of us say we can do this by the eyeball test, but the eyeball test actually isn't quite right in terms of discerning frailty. And there's a Rockwell score as well. It's a 72 questionnaire that asks all kinds of different questions. And even if you don't ask all 72, you get a percentage of these correct, if you will, or positive. Then that will also be a scale for frailty as well. And for heart patients with VADs it's a little difficult because these are for ambulatory patients. Gait speed is ambulatory. You have somebody who comes in who is in cardiogenic shock, or maybe not, just in an acute decompensated heart failure, they're not going to be able to get up. But the hand grip strength actually is a pretty good marker for whether or not they're frail or not. And when you look at outcome for frail patients, as you move up on the Fried scale, you have higher mortality, both perioperatively and postoperatively as well. And people say, well, you can give them nutrition, you can give them prehabilitation, but that takes time. And you don't really have time for these patients to do that. Because it will take months to really get their nutritional state up rather than just give IV alimentation. That's not going to work. So it is an issue. It is a problem that is coming up, and certainly with MCS, as well. But can MCS make them better? We think so, perhaps so, and I think that's going to be one of the areas to pursue. And there's a difference between frailty and aging, by the way. Maybe a lot of people think they're synonymous, but they're not. There are actually differences in inflammation. And inflammation is, everything's inflammation as it is now. But there's actually more inflammation with frailty. And there are some biomarkers that one can look at too that are different from the aging phenomenon. So there's a lot going on in terms of what we can do, what can be done. And it's different for different entities. In heart failure, you're not going to have weight loss. You're going to have weight gain. That's a problem. In liver transplantation, it's one of the things we don't see is cognition, and that should be taken into account as well. And that's a big issue. And how do you put that in? There's a Montreal score that one can use for cognition, but it's again different for different entities. In liver transplantation, they would never do that. Everyone's encephalopathic, so it doesn't really count. But that's why there are a lot of differences in organs per se. But in cardiac, I think it's something that should be taken into account.
Yeah, and you bring up cognitive frailty, which clearly is adds to the physical frailty. And you also talked about the challenges of reversing frailty. Just curious though, when you are screening patients for their candidacy for LVAD or candidacy for transplant, have you systematized your approach at Cedars-Sinai? Do you screen everyone for frailty?
Yeah, we do. We actually use a Fried scale. We actually give scores to every single one of our patients that come in. Our social workers and nutritionists actually do that on a routine basis. It's always an issue of who's going to do that, as opposed to the physical therapist. And it doesn't really matter as long as it's done in a systematic approach and they use the same criteria.
And do you use that in your decision-making in terms of candidacy? Would you turn someone down solely on the basis of frailty?
No, we won't. I mean, we will take into account that as a relative contraindication. So as these relative contraindications stack up, yes, that would be part of an absolute contraindication.
Good. So Laura, I want to ask you, we've talked a lot about selecting patients for advanced therapies, and clearly we are focusing on survival, we're focusing on reducing morbidity, reducing mortality. How do we get the patient's voice in this process? And Luke also mentioned shared decision-making. Can you tell us a little bit more about that and how we go about that here at Mount Sinai?
Great, yeah. Thank you for including me in the panel. So, I think one of the two of the really fundamental ways in which in this population we can bring the patient's voice to the table is, one, really helping with that prognostic alignment that you were talking about earlier, where there are multiple studies have shown that patients' perception of their prognosis, if they were to give an estimate of patients who have markers of high mortality or high morbidity with heart failure, would say that they are likely to live for at least 5 years. Whereas if you ask the physician that same question, they'll say, a small percentage would live more than a year. So that big discrepancy between the patient's perception and the clinician's perception, I think there's a great opportunity there to help with that prognostic alignment going forward and bringing the patient's voice in terms of their own perceptions of where they are in their illness trajectory, and sort of getting a better sense of what matters most to them. And then I think the other way is to really think about the what ifs. So, we've talked about survival and quality of life, and, the vast majority of patients, when offered a therapy that would both improve their survival and quality of life, will say yes. And, I think we all support that. I think it's really the question of what happens when things don't go well, and trying to have that conversation up front, and in an iterative fashion to make sure that as those preferences may change over time, that they're clear to all the clinicians caring for them, and also clear to their family, because I think the other piece to all of this is not only the patient's voice, but the caregiver's voice. The caregivers of these patients face tremendous burdens and responsibilities, and I think by bringing the patient's voice forward in terms of what matters most to them, it alleviates a lot of the burden on the caregivers.
It's true, right? It's always harder on the caregivers, always harder. Are there any tools out there for patients and their families, particularly as they go through in terms of making a decision as to whether or not to accept these therapies?
Yeah, so there are a number of decision aids. There's a relatively recently published decision aid called Decide LVAD in particular, which is a decision aid in which the sort of goal is to sort of map out what are the potential risks and benefits to receiving an LVAD and sort of helping patients identify where they would want to land. And the study showed that the patients who were in the intervention arm actually they were more likely to have alignment between the treatments that they wanted and the treatments that they were offered, however, not with the treatments that were received. And I think that discrepancy with what the treatments were that they actually received weren't as aligned with what they wanted is more of probably the systems surrounding it, so eligibility and candidacy. So there's some tools out there, although they're not used widely, I think, in the clinical setting. And I think a lot of it really comes down to just having a conversation, and probably sort of the more low-tech version of helping patients understand what the potential consequences are of the various interventions.
Great, thank you. So Sumit, I want to put a slide up. You're probably going to have a hard time seeing it, but I said I had mentioned that I would show a slide from COAPT. And so this is taken from the New England Journal of Medicine publication, Greg Stone's publication of the COAPT trial looking at MitraClip in patients with systolic heart failure, EFs between 20 and 50%, moderate to severe mitral regurgitation, New York Heart Association class 2, 3, or 4A, meaning ambulatory. And this is survival, or the other way of looking at it, all-cause mortality. And you can see the control group at 2 years had a mortality of 40%. The device group had a mortality at 2 years of between 20, 22%, something like that. If you compare that to the outcomes that we have with ventricular assist devices right now, Momentum 3 trial had a 1-year survival of almost 83%. So a 2-year survival of 83%. So a 2-year mortality of 17%, and clearly a much sicker population than that is being considered here. Don't you think that what we really need now, as we begin to have a number of therapeutics for patients with more advancing heart failure, is a better way to phenotype them in order to select the right therapy for them?
Absolutely, and I think what this speaks to is a large thing is actually having a heart team to evaluate these patients in your aggregate, your interventionists, your valve specialists, your echocardiologists, your heart failure doctors, your surgeons, to really see what's going to be the best approach for this patient. Because when we want to phenotype it, we need to figure out, is the MitraClip actually going to reduce that left atrial pressure enough to make the patient asymptomatic, maybe, and also reduce the MR to the degree and that part of the myopathy reverses and they do better? Or do they actually need an LVAD? Is the myopathy so severe that putting a MitraClip in isn't going to help? And so I think we need to have that upfront evaluation, that earlier evaluation, to sit there and decide what's our best course of therapy when they're not, when we think we've hit our threshold with medical therapy. And it speaks to our improved survival HeartMate 3 that can actually deliver an outcome that we want, that with reduced mortality at 2 years, that's so significant, even compared to a valve intervention.
Yeah, I think the challenge is to properly identify patients and triage them to the right therapy. And it really gets back to our previous conversation about how do you prognosticate in the setting of heart failure. When is it appropriate to put in a mitral clip? When is it appropriate to proceed to advanced therapies? One of the things that I'm reminded of was something that Joe Rogers from Duke used to somewhat joke about, and that is that people would show up and you would call it the steri-strip sign. And that is that they basically went from the EP, got their CRT, oops, it didn't work, and then they'd show up in heart failure clinic for VAD and transplant evaluation. The steri-strips were still covering the wound. But I think, again, I say that not pejoratively, but to say that we really do have a difficult time. We really do struggle to define the right therapy for the right patients. I think this is going to be, I would phrase it as an opportunity for those of us who work in this space to direct patients, the right patient to the right therapy. I don't know, John, if you have any thoughts or any wisdom that way.
Yes, I think a lot of it has to do with the phenotype. We don't really know the phenotype here, and we don't really have the big data to really know what exactly is the high-risk patient. And in a way, we're looking at that right now. I mean, kidneys have done it with the kidney eye box, and we're working on it with a cardiac eye box to try to get all the big data together to see what is the phenotypic milieu of the high-risk patient, and what are the outcomes if you go this route or that route, because it's different for every group, but also to take into account the caliber of your interventionalist as well. I mean, that's a problem too. If you've only done 6 mitral valve clips as compared to doing 100, it's a different outcome as well. So there's a lot of variables that go into play here too. You have to know your team. And as Joe Rogers always says, and if you put out, it's a team. You have to have all the experts come together and make a rational decision and the best decision for your patient, take into account all the phenotypes that are there, that that are there. And I think that would be the best approach. But it's got to be a team play, and it's got to be done by experts. It cannot be done with community, physicians who don't understand advanced heart disease. And I think that's where the major centers have to be the places where this type of intervention actually does take place.
That's great. So Amit, I want to ask you, we talked a little bit about the Momentum 3 data, very impressive 2-year survival. I would say the elimination of pump thrombosis as an adverse event, a reduction in stroke, but not an elimination of stroke, and certainly not an elimination of gastrointestinal bleeding with rates as high as 25 or 30%. But having said that, should we be considering implanting ventricular assist devices, specifically the newer generation ventricular assist devices, in patients who are less sick? And typically, we would mean Intermax 4 through 7, folks who are clearly sick, they're exertionally limited, but are not currently inotrope dependent. What do you think?
I think yes, but we will need to wait for a little longer term data, like what happens to these patients at 3 years, 4 years, 5 years. And if the rate of complications or survival is good, then we can apply to lower Intermax patients.
So in not only improving survival, but what do you think about adverse events? I mean, is that the deciding factor now as to whether or not to implant an LVAD into these less sick patients?
Yes, so with this Momentum 3 trial, the risk of like pump thrombosis has gone down. So if stroke rate, driveline infection, GI bleeding also go down with time, then we can apply more and more to less sicker patients.
And Ani, where do you think the choke point is? Why aren't we seeing more patients referred for destination therapy in this lower risk cohort?
I mean, I think the risk profile with the devices is still very high. I think somewhere around 40 to 50% of patients will be rehospitalized within the first year, and probably about 2/3 within by the end of the second year. We don't know how this balances against the quality of life they have when they're in heart failure. And unfortunately, most of the studies have been based on patient survival. But for this patient group you're talking about, it's not about survival because most of them will be alive, say, a year from now. So you're doing the intervention to improve their quality of life. And what we really need is randomized trials now in these lower risk patient cohort, which is actually looking at an aggregate measure of quality of life, something like the Euroqual, something that can capture all dimensions of quality of life and work out, because you're trading one disease for another. You're trading the disease of heart failure with the disease of having a device, which doesn't occur in the higher Intermax group, because in that case, you're trading certain death with being alive, but with some inconvenience. So I think, I don't think we're there to expand to less sick patients, but I think we're at the point where we need to study it and get the data.
I think those are my two takeaways from Roadmap that Dr. Kobayashi mentioned. It was an observational trial of patients who were ambulatory heart failure who either selected to have an LVAD implanted or selected not to have an LVAD implanted, but were eligible for an LVAD. So the first was, as you said, that the survival was the same between the two, which means that for those individuals who ultimately decided that they wanted an LVAD down the road, they didn't pay a mortality price. They didn't risk survival as a result of delaying that decision. But the other was to look at the reasons why people who chose to have the device chose the device, and it was because they had a really, really poor quality of life. And so I think what drove those individuals to select the device was a clear desire to feel better, regardless of whether or not it was going to help extend their survival. Well, I want to leave the world of VADs and really take advantage of having Dr. Kobayashi here to talk about heart transplant in the remaining 5 or 10 minutes. And John, you know, we're wrapping up our celebration of the 50th anniversary of heart transplantation, the first heart transplant being performed in 1967. I would say, looking at the audience, at least half the people in this room weren't alive in 1967 when the first human heart transplant was performed by Dr. Christian Barnard in Cape Town, South Africa. And it's really been remarkable, and John, you talked about this at your lunchtime lecture, that the early survival was dismal. There's no other way to say it. It took a technological breakthrough, the development of effective immune suppression, to see survival improve, and with that we saw a sudden and dramatic and sustained increase in the volume of transplant until we were restrained by the number of available donors. And we've really lived in that period in the last 2 decades, which is a lot of demand but not a lot of supply. You know, as someone who is such a leader in this field, where is this field going? We know very well where we've been, but where are we going? How do we continue to advance?
Well, I think there are a number of potential possibilities that do come up in terms of increasing the donor pool. One is xenotransplantation. We're actually getting much better using pig hearts and using knockout pigs, and also CRISPR-9 technology, you know, may actually revolutionize how we look at these donors. You know, these are large pigs that can supply a donor heart to a smaller human. And that may be a possibility. Are we there yet? Well, the kidney transplant world is actually starting to look at these as a possibility. We'll have to see whether or not they actually do create a viable alternative. The problem is the zoonosis, whether or not you're going to transmit, you know, pig viruses to humans. But even that is being addressed at this point in time too. So that's one area. Now, you know, will the devices get better, tetherless devices and reduction of adverse events? We're hoping so, because once that becomes available, you ramp down the adverse events, particularly stroke. I mean, that's unforgiving, and there is worse than death, and that's stroke. If you can't express yourself, you can't talk, can't move half your body, and no one can predict what type of stroke, and you're not privy to determining, I'm going to have a lesser stroke than the other guy. So that's problematic, but that's a future as well. In terms of expanding the donor pool, maybe so. The heart-in-the-box technology is here. It just has to be FDA approved. Maybe we'll be able to go across the country. Maybe New York can take LA hearts. I don't know about that. I think maybe we'd like to take New York hearts to Los Angeles. But nonetheless, that will also open up the donor pool and make use of every single donor, and also using extended criteria donor hearts. Donor awareness comes up. I mean, there's so many different facets one can use to expand the donor pool, but also alternatives to heart transplantation as well. So I think the future is there, a lot of different avenues to go, even organ engineering, but I think that's more science fiction right now compared to the other alternatives that are there. I'll stop here. There's a lot to go.
So, Amit, let me come back to you. And you were instrumental in our use of the Heart in the Box, the Transmedics device, and harvesting these hearts and putting them on essentially what is a Langendorf preparation, keeping the heart beating, keeping it warm while it travels long distances, allowing us to sample off lactate to make sure that the heart is performing okay and not getting sicker during transport. What's your feeling about using this technology combined with DCD donation, so donation after circulatory death? It's being used in England, it's being used in Australia. Do you think this is a modality that we can use here in the United States to try to expand the donor pool?
Yes, there is a role for ex vivo perfusion for DCD donors, but in United States there has to be a policy for DCD donor, which is still developing for DCD transplantation. So, but there will be a role for ex vivo perfusion.
John, do you have any trepidation about that type of transplantation? It's always been daunting to me to say that we're going to let someone die of cardiac death and then take their heart out and transplant it into someone else and hope for a good outcome. What do you think?
Well, when you think about it, our current donors do have a great degree of downtime. And is that the same as DCD donors? Well, I would submit that these DCD donors are actually less so. You've got a 5-minute standoff time. And when you think about it, many of our donors have much longer downtime than 5 minutes. And so, and these are usually younger donors. So you're talking about younger donors, shorter ischemic time because you're going to be right there. It's more or less planned in a sense. So I think it's quite viable. And in fact, DC donors may increase the donor pool by as much as 30%, depending on where you are, of course. And that, I think, is a big plus. You know, therapies have to be perfected, though. And there is an issue of why not just warm reperfusion? You know, clamp the carotids, clamp the vertebrals, restart the heart with the ECMO support, and then you'll see whether the quality is there or not. And that's one thing that Stephen Sui is doing in England as well. So, I mean, so there are some issues, some alternatives that may be used as opposed to going to the heart in the box and then going to the recipient. But no matter what, I think it's a viable alternative and something that will certainly be in the future. They're doing it well in Australia and England and other places as well. It's just the U.S. has a very litigious society, so we have to get through all that too in terms of making sure everything is done correctly.
Good. Well, we're up on 6 o'clock, so I just want to sum up before we open up for questions. So, initiate and escalate medical therapy for those patients with heart failure. Refer early. Screen for those signs of stage D heart failure, including recurrent hospitalization, ICD shocks, inability to tolerate guideline-directed medical therapy, and continue to work to define the right treatment for the right patient phenotype with the use of MitraClip, cardiac resynchronization, LVAD, and transplant. So again, I'd like to thank Dr. Kobayashi and the panel, and then open it up to any questions that you might have. Sandy.
So I looked up the Seattle score on my iPhone, and I see that two interesting things. The allopurinol was mentioned, the ACE inhibitors and all that. And I thought that was curious. I wanted to know what you thought about that. But more important, I didn't see Entresto in that at all. And I want to know what you think about that as an important tool.
Maya, what do you think about that?
I think that's a very good question about Entresto. This has not been revalidated with the ARNI era, so I think it would be very important to revalidate in that setting, since there is a significant advantage to using ARNIs over ACEs or ARBs in chronic heart failure patients.
Do you want to talk about allopurinol?
I can't really speak to why that's there. Maybe someone else on the panel can.
It's amazing when you do multivariable risk scores, what shakes out. So one of the thoughts with allopurinol was that you had a higher inflammatory state in advanced heart failure, and allopurinol may have some anti-inflammatory properties.
I mean, Sean, the other problem though is when was this score developed? At least 10 years ago or 15?
At least 10 years ago.
And
Yeah.
it was probably developed on patients who were treated in the 1990s.
That's
and
correct.
The question is, what relevance does that past and history have on patients being treated today? For example, you've just put the MitraClip up there. It didn't exist 20 years ago. And I think the problem with risk scores, unless something like the STS score, which you mentioned, which is revalidated and changed, all the weightings are changed on an annual basis, and sometimes risk factors drop, new ones are included. So that's a living risk score. But most of these risk scores are dead the moment they're published their history, but yet we still use them to predict the future.
No, you're absolutely right that the derivation database was a collection of about 4 or 5 heart failure trials that were conducted in the 80s and the early 90s. And so this risk score has undergone some tweaks to try to improve the calibration. Where it missed the most was in patients with advanced heart failure. And in fact, it significantly overestimated survival in the group of patients who had advanced heart failure. And so Wayne Levy and his colleagues at Seattle at the University of Washington have tried to do some back-end tweaks to try to improve the calibration. But your point's absolutely right, and I think it does speak to the limitation of using these multivariable risk scores. And although it is in the guidelines to consider using them to try to assess prognosis, it clearly states in the ISHLT guidelines and in the ACC-AHA guidelines that you should never use that as the sole criteria for selecting someone for transplantation. Other questions? All right. Well, thank you again for your attention, and thanks again for Dr. Kobayashi.